in the System of Care Expansion series. Daring Dialogues, Understanding Cultural and Linguistic Competence in a System of Care Framework in Texas. Thanks for bearing with us. We had a couple of technical difficulties starting out, but as I go forward and give you some background on the System of Care grant and the purpose of this webinar, we'd like for you to take this poll. I'm going to open it now. On the front of your screen, please answer the question of what organization type or perspective do you represent for this webinar? As we mentioned, this is the third in our series to date as a part of the System of Care Expansion Planning Grant that we received from SAMHSA. The intent of this webinar is to increase the system of care readiness around cultural and linguistic competence. And it'll be comprised of three components. The first component is going to focus on System of Care Value 3, basically covering the what and why of cultural and linguistic competence. And that'll be covered by Ms. Joyce James from the Center for the Elimination of Disproportionality and Disparities at the Health and Human Services Commission. The second portion of the webinar is designed to cover System of Care Value number 2, which is, how can communities address cultural and linguistic competence? And during that portion of the webinar, we will be speaking to Wendy Auerbach from the Center for Excellence in Culturally Competent Mental Health with the Nathan Klein Institute for Psychiatric Research out of New York. Then we will also be speaking to Mr. Esteban Zubia from the El Paso County Department of Mental Health. And in both those speakers' presentations, they will be speaking to the topic of how can a community either use a toolkit that's been designed to address cultural and linguistic competence, or how do you do it if you don't have any guidance or structure, and why should you do it? So with that being said, I'm going to turn the webinar over to Ms. Joyce James with the Center for the Elimination of Disproportionality and Disparities.
Thank you, Erin. Good morning. This morning I will be talking to you about the Center for Elimination of Disproportionality and Disparities, the Texas model for addressing disproportionality and disparities, and a conversation in which we believe it takes us deeper into an analysis and understanding why we continue to have disproportionality and health disparities in spite of all of the work that we've been doing. But first I'd like to introduce you to the center. The mission of the center is to partner with health and human services agencies, external stakeholders, other systems, and community to identify and eliminate disproportionality and disparities affecting children, families, and vulnerable populations. The charge of the center is to work to reduce and ultimately eliminate disproportionality and disparities that affect unserved and underserved populations. We're really excited about the vision behind this work because it is our real life experience and the efforts in which this work started, which was in the Department of Family and Protective Services, Child Protective Services program, which taught us that the best strategies and practices to address disproportionality and reduce or eliminate health disparities begins with looking at the data, sharing data about health inequity and disparities with the communities that are most affected as well as the broader community, and a shared responsibility of community and systems to improve outcomes of vulnerable populations. It's been about 2 years now since our executive commissioner established the center to work with all of the health and human services systems in the state of Texas and to expand the use of the Texas model to achieve significant improvements in the Department of Family and Protective Services to other systems and programs serving the same vulnerable populations. In addition, the decision to move the former Office for the Elimination of Health Disparities into the structure of the center actually sent a message of the importance of understanding the link between disproportionality and disparities. And so I would like to just share some terms with you that we generally use to describe racial inequities in outcomes across systems. And I hope that what it will do is help us to understand the relationship that systems have to the same vulnerable population. So at the core of the work of our center is the realization that racial inequities exist across every system. Different systems have developed different terminology, but the racial inequities actually show up everywhere. And so if you look at the first term on the screen, which is disproportionality, you will see that this is the term that child welfare uses to frequently discuss the overrepresentation of a particular group or race in a system as compared to their representation in the general population. And so in juvenile justice, we talk about disproportionate minority contact. In education, we talk about the achievement gap. But we believe that it is really, really important that we address the disproportionality and disparities in every one of these systems if we are to eliminate it in any one of them. There is a direct relationship between how these systems produce the same or similar outcomes for the same population of people. To address them, we have taken a pretty bold approach at the center, and we have found that it is really critical for us to begin to engage in a different, new, and courageous conversation in understanding the underlying cause of the production of these outcomes for the same population. And so we have introduced in our work at the center the concept of institutionalized racism. Now, it's not a term that people generally think about when we're doing our work because we all have many different definitions of what we mean when we're saying racism. Our work is to help people to really come to a common understanding and a common definition, and to realize that we're not talking about individual acts of meanness, hatred, or bigotry, but we're actually talking about systemic issues that have continued to produce disproportionate and disparate outcomes for similar groups of people. Disproportionality and disparities are linked, and I'd like to talk about what that linkage is. So disparities in treatment can lead to or perpetuate disproportionality and vice versa. Furthermore, as I mentioned, disproportionality in one system can lead to disparities in another. For example, if you will look at the chart that is currently on the screen, it shows that disparate treatment in child welfare means that African American children are more likely to be removed from their homes. That disparity in treatment leads to disproportionate number of children in foster care. The data also suggests that children in foster care are less likely to graduate from high school and less likely to reach college age, so that disproportionality in child welfare can contribute to disparate outcomes in education as well as in health. And since education is so closely correlated with many health outcomes, health disparities are also closely and clearly connected. Recent studies on racial disparities in discipline across the country as well as in Texas and the resultant impact show a direct correlation between school discipline and poor health outcomes for African Americans, Hispanic Latino population, as well as children with limited abilities. Because the report and research shows that multiple disciplinary actions result in referrals to juvenile probation, which ultimately results in a higher potential for being involved in the criminal justice system, we know that that population often experiences poor health outcomes. The research also shows that Children who receive multiple disciplinary actions are more likely to drop out of school. The impact that that has on determining where a person can later live and work, what type of job they will have access to, their ability to access the services and resources that they need to care for themselves and their families. And there is a direct connection in terms of the type of work that they do, and their wage earning capacity impacts the ability that they may have to support preventative health measures and acquiring those services that are necessary for good health. And it really speaks to the fact that it is Black and brown youth who are most negatively impacted by discipline in schools. They're also more likely to drop out of school. And in Texas, they also lead the way in dying from 7 of the 10 leading causes of death in the state of Texas. And so we present this slide to really show that it is very, very important for us to understand the relationship that communities of color, the poor, and other vulnerable populations have to all of the systems, and how what happens in one system has a direct impact on outcomes and whether or not a person may potentially become involved in one of the other systems. I'd like to spend just a little bit of time before I actually go into the components of the Texas model, which we believe is a model that can be applied to work in any system that is striving to produce equity or improve outcomes for vulnerable populations. And so I want to talk just briefly about how this started. And again, as I mentioned previously, the work actually started in the Child Protective Services program. And it evolved in Southeast Texas, beginning in the Beaumont and Port Arthur area, where I happened to be a regional director at the time. And I actually started my career in Child Protective Services as a Child Protective Services caseworker, and experienced in that work quite a bit of uncomfortableness with my belief that there was not a true understanding of the culture and history of all of the people that we were charged with serving in our work. And so I saw some disproportionality and disparities produced by well-meaning people inside of a system because we lack the understanding of history and culture, which we believe is so important and why it is a critical component of the model that we have developed. And so in isolation of going into full detail about the history, I do want to share that it became really important as I struggled as a caseworker with my individual caseload in areas of concern that I struggled to elevate and speak out about, that really we began to ultimately see that that was more than about the individual caseload that I had. And as I moved up the career ladder and saw it on a much broader scale as a supervisor and a program director and ultimately a regional director, I began to have a deeper and better understanding of why it would be important for us to really begin to examine the level of cultural competency that exists within our agency, why it would be important to really begin to engage the people whose lives were so profoundly impacted by our work in this process, and to learn from them, and to also make sure that there was mutual respect and accountability between the community and the systems that were seeking to serve vulnerable populations. And so at the regional level, that work started. The model began to develop. We began to understand that the families and children that were served in Child Protective Services were often interfacing with various other systems, juvenile justice, education. They were involved with the healthcare system, and yet the systems continued to work in a siloed approach, and we were not really collaborating in a way that would break down barriers and challenges for people who were trying to access all of our various systems. And so moving that work from a regional level to statewide expansion of the work in 2004 in Child Protective Services, and beginning to really use a model that said that we had to engage with other systems, we had to begin to engage the community, and we had to begin to understand the importance of culture and history for vulnerable populations at a much deeper level. It was at a time in 2004 when I ultimately became the State Director for Child Protective Services that the state of Texas recognized the disproportionality and disparity that exists in Child Protective Services, and ruling out many of the factors that we had attributed to this, we were able to begin to examine in a more meaningful way the existence of racial bias in decision making, implicit, unconscious bias on the part of well-meaning people that eventually led to Texas becoming the first state in the country to have legislation requiring Child Protective Services to work to remediate its enforcement actions and to reduce disproportionality. We were ultimately able, through the development of the model, to reduce the disproportionate number of African American and Native American children in the Texas child welfare system, and to produce some overall improved outcomes for all populations that were served. We would move on at the state legislature to have 2 more pieces of legislation in this state that would ultimately create our center. And we would have the opportunity to then begin to move this model into practice into other health and human services systems. And so I would like to at this time go into the model, starting with data-driven strategies, and really emphasizing that the place to begin this work has to be with the data, that it is necessary that all data be collected, researched, evaluated, and reported by race, that data is compared to the racial and ethnic populations of the defined area, and that it is examined through a systemic and cross-systems perspective, and that it is shared transparently with systems and the communities who are affected by the data outcomes. Leadership development means growing leaders that are grounded in anti-racist principles, are courageous, who understand and are addressing their own internalized racial oppression, that they understand some of the reasons why we so often work with poor communities and communities of color, and that we hold ourselves accountable for asking the question, why are people poor? And that we examine our thinking and how we've been socialized to believe around those issues and how that might contribute to the way in which we serve vulnerable populations. The culturally competent workforce is really, really critical. It means that we have to develop a workforce where everyone is trained in anti-racist principles, whose humanity demonstrates best practice through service delivery and access to programs and services, and who reviews and examines their work through a lens which focuses on ensuring equity while improving outcomes in partnership with the community. Community engagement, methods of engaging the grassroots community through transparency and communication that is respectful, recognizes the community's strengths, hears their ideas, and includes them as partners. That means we must have parents, youth, and other vulnerable citizens in dialogue, in discussions, in the very beginning of planning and decision-making on efforts that will impact them and their communities. There must be a component that involves cross-systems collaborations. It means identifying and building relationships and partnerships with communities, other systems, institutions, and agencies whose services, programs, policies, and practices impact the same or similar populations. We must be willing to share data transparently, develop and implement cross-systems training, ongoing dialogue, and methods to transfer learning that includes the populations who are affected in this process. And then the training that is defined by anti-racist principles. We believe that all parties who are involved in this process should be trained, and we have based our training on the anti-racist principles that are outlined by the People's Institute for Survival and Beyond. They include learning from history, developing leadership, maintaining accountability to the communities that we serve, creating networks, undoing internalized racial oppression, and understanding the role of organizational gatekeeping as a mechanism for perpetuating institutionalized racism. We use these principles to guide our institutional and cultural level work, in addition to addressing the symptoms of these underlying issues as they manifest themselves in our state agencies. The Texas model requires that we approach our work with a sense of how we got here. The outcomes that we see in our systems are results of a particular historical process, and to change them, we need to understand the history. The model that we use here actually can be compared to two national initiatives to address health and health disparities. The one column is Healthy People 2020, column 2 is the National Partnership for Action, and column 3 is the Texas model. If you will look along the arrow on the side, you will see that the model actually can be separated from the other work currently being done. The circle on the bottom right shows that the Texas model actually prioritizes community engagement. And it prioritizes by making sure that training occurs. Not only does it occur within systems, but it also occurs within the impacted communities. So we bring these elements into every other part of our work. We use data, for example, and all of the data is shared with the community, and it is analyzed through an anti-racist lens. With leadership development, we don't only develop leadership inside of the institution, but we work with the community to develop and train leaders within the community. We don't only train our staff in cultural competency, but we use community engagement and partnership as a method for all involved to become culturally competent. The communities we serve have a culture that we need to understand, but we also have an institutional culture that is creating many of the poor outcomes that we see. At the center, we feel that these elements of community engagement, anti-racist principles, and an understanding of the history of institutionalized racism are as necessary for our work in health disparities as they are for child welfare and all other systems that serve vulnerable populations. And so, in closing, I would like to say that it has been a decade since the 1985 landmark report was released by the U.S. Department of Health and Human Services, documenting the existence of health disparities for minorities. The report called these disparities an affront to our ideals and to the ongoing genius of American medicine. This statement is still so very true today, and in fact, the gap continues to grow for racial and ethnic minorities. At the center, we have committed to a new approach, a new, bold, and courageous conversation that underscores the fact that what we have been doing has not worked. We can no longer focus solely on what is wrong with those who bear the burden of our poor outcomes that are produced by all of our systems, but we must also understand the necessity of turning the mirror inward to examine the response of systems to vulnerable populations. And that means taking cultural competency to a new and deeper level. Thank you.
Thank you, Joyce. Thanks for providing that broad framework for the awesome work that you guys in your office and that the legislature has started with your center, and kind of providing the context of the larger and broader picture of cultural and linguistic competence, and especially in the work that you guys do. So we appreciate that very much. Next, we're going to be turning to Miss Wendy from New York, Wendy Schudrick. She'll be joined by Dr. Charles Auerbach. I'm going to mess up your last name, Charles. I'm sorry. But I failed to mention him earlier, and that was a mistake on my part, because Dr. Auerbach has been the lead evaluator for 2 U.S. Children's Bureau-funded longitudinal studies on recruitment and retention of child welfare workers over the past 9 years. He's also been instrumental in helping Wendy as she was working with the Nathan Klein Institute on developing a toolkit for modifying evidence-based practices to increase cultural competence. And I'm really pleased that they were both able to join us today on this webinar to talk about their toolkit, how it's been used in other states, and maybe some of its applicability to us. So, Wendy, if you want to start your webcam and turn your mic on, I'm going to turn it over to you.
Okay, thank you so much, Erin. I hope everybody can see us here. I'm trying to go back. Okay. Thank you so much, actually, Erin, for inviting us to join you today. The topic of our talk is called the Toolkit for Modifying Evidence-Based Practices to Increase Cultural Competence, and that is, in fact, the name of our manuscript that I'm going to show you how you can access today. We've developed and are making freely available to really anybody our toolkit. That encompasses quite a bit of material, and we're going to show you not only how to access it, but what's in it today. And I think this is especially appropriate in addition to the work done at the Nathan Klein Institute on the toolkit that we're going to be describing to you this morning. Both myself and my co-presenter, Charles Auerbach, and I do extensive work in child welfare research as well in New York, so it's extremely appropriate that we're following Ms. James. And much of what you hear in our presentation is going to piggyback on and expand on some of the concepts that Ms. James talked about in her talk and bring it into the practice realm directly with consumers. So this is what we're going to be covering for you today. Our topics are, we're going to talk about the development of the toolkit, like why and how it was developed. And we're going to provide you with an overview of the methodology in the toolkit and how it's been used, because not only do you want to know that, yes, we have this manuscript out there, but that folks are using it and how they're using it. We can demonstrate that for you. And then we're going to discuss with you the feedback that we've gotten from communities on the benefits of using the toolkit. And then we're going to describe to you some of the future activities, where is the toolkit going, and what we see as developing as an offshoot of this. And then we're going to try to give you a few minutes to answer some questions, to ask some questions about it. So the toolkit, as Erin described to you earlier, was developed with funding from the Nathan Klein Institute for Culturally Competent Mental Health. Nathan Klein is one of 2 state-funded mental health research facilities in the state of New York. What we do within the center is study the intersection of mental health and culture. And the idea is to develop practical tools to help agencies achieve a high level of cultural competence in the delivery of services. So we're trying to do some research, but also take it down to the practitioner level that can be used within agencies or systems to provide culturally competent services to consumers. And we also do some training of agencies and practitioners so they can apply our tools within their organizations, again with the goal of engaging consumers and improving outcomes. The development of the toolkit itself was a multidisciplinary collaboration. My background in training is in social work, but the other developers that were involved in the toolkit development and testing and editing process come from the fields of public health and child psychiatry and psychology and psychiatric nursing. So I just wanted to give you some context as to how the toolkit was developed. So within the center, we were working on various projects, and we decided that there was a need to modify evidence-based practices for cultural groups. And we discovered this from quite a bit of study that we did ourselves. But what we found is that there is a need for effective mental health services for various cultural groups. And we found mostly through our review of SAMHSA evidence-based practices on their website that there have been a lot of evidence-based practices that have been developed, but not necessarily with cultural groups in mind. Or evidence-based practices may have been developed with cultural groups in mind, but not necessarily tested for effectiveness. And thirdly, we found that they may have been tested and developed with cultural groups in mind, but not all materials, such as training manuals or consumer materials, reflect the breadth of the culture served. And so to begin our research and work on the development of the toolkit, we used SAMHSA's Registry of Evidence-Based Practices, and we noted that they include a growing list of effective interventions. And we chose SAMHSA's registry really for two reasons. First of all, there are many other registries out there, but they often overlap with the content that's on SAMHSA's website. And also that there's really no doubt that this is really the gold standard of evidence-based practices. Also, in our search for projects within the center, we also realized that while there's a lot of cultural modification going on out there in the community, there really seems to be no systematic method for considering these modifications to evidence-based practices. That is, we know that these modifications are being done, but they're also often done in a haphazard manner, which means that there seems to be no comprehensive manner for thinking about how research should be done. So the screen that you see now is, and I know it might be hard to see because the print is small, but this is an overview of the methodology presented in the toolkit. And it begins with the underlying assumption that the agency or system within that wants to do a cultural modification has already identified a problem or a need for a specific cultural group or a defined multicultural group. And then, so the following describes, this flow describes the basic flow of the toolkit. As you can see, working with communities is an umbrella over the entire process. And throughout the toolkit, we refer back to a working group, which I'll describe to you in just a bit, but how the working group, which is comprised of both agency staff and community members, goes about the task of selecting an appropriate evidence-based practice, and then going about the modification process, and then dealing with implementation issues. So the next group of slides we're going to go through, I'm going to give you an overview of each of the sections described here. And each of these sections is described in a chapter in the toolkit. So actually, the first chapter in the toolkit is an introductory chapter that sort of sets the stage for cultural modification and brings everybody onto the same page with key definitions. But the first task-based chapter is called Working with Communities. And the goal of this, really working with communities in general, is to increase knowledge about cultural groups and their mental health needs for the agency or the system, and the benefits for the community are to really try to increase acceptance of services. And the overall goal is to create an equal and reciprocal relationship between the agency or the system and the community. And we've been seeing this notion increasingly promoted in larger systems of care, with consumer groups being empowered through things like involvement in professional conferences and webinars like we're participating in today. So the chapter on working with communities hinges on the development and work of a working group. And this is an agency, a combined agency and community-based group that works together throughout the process of cultural modification. And this chapter goes into great detail on determining who to include in your working group and why, and how to invite them to participate in the working group. And so there's recruitment activities discussed in there. And then working together, the actual collaboration on working on modifications, and then working together through implementation issues. So it's really involving the entire working group through the entire cultural modification process. The next chapter is called Selecting an Evidence-Based Practice. Now, we're going to recognize in the development of the toolkit that not every agency or system is going to need this guidance. Some agencies already have an evidence-based practice that they're working with and really just would like to modify it to make it more culturally appropriate for the clients that they're serving. Other agencies or systems are going to have mandated services based on funding. But we do recognize that many agencies do have to go ahead and make a selection of an evidence-based practice. So there are different sections to this chapter, and the first section goes about describing how to identify possible evidence-based practices that are going to meet the clinical needs of the groups being served. And then we go into detail on evaluating the cultural appropriateness of evidence-based practices. We present two paradigms on determining cultural fit between the agency, between the culture and the practice. And then we provide you with information on pragmatic considerations that touch on culture, but also deal with things such as cost and training and providers and skills. And then we go into detail on identifying the need for cultural modifications. We recognize that not every evidence-based practice is going to be massive cultural modifications, so we go into some detail and provide you with some information on how to compare and contrast different evidence-based practices that the agency or a system may be considering to determine the level of need for cultural modification. And then the last section in this chapter goes into some detail on how you actually go about making a final decision and then providing justification to your funders and other stakeholders, both within the system or agency and the community. The next chapter in the toolkit is called Modifying Evidence-Based Practices, and this chapter describes how to actually go about doing a cultural modification. So the first step is, and I will go into more detail on this because this is a very detailed chapter, is to break down the evidence-based practice that your agency is going to be using, or the system, into components, using the helping process model to determine which components need to be modified. Then we provide you information on how to go about doing the actual modification itself, and then provide you with some resources for documenting the modification, because once you actually make a modification to an evidence-based practice, voila, you now have a new practice. So it's important to document what you have, because then you're going to want to go about piloting the modified evidence-based practice, and based upon the pilot, you may go back and tweak it and find things that work better or worse for your agency or system. And then we go about giving you some information about and reminding you to evaluate the success of the modification. And this is really important, not just for your own particular agency or system, but again, to share knowledge across systems. So I wanted to tell you a little bit more about breaking down the evidence-based practice into its components using the helping process. So this is our framework that we built based upon that. When we did a study of existing evidence-based practices, we have a little bit of a, we're not exactly, Erin, we're having a little bit of a problem with this slide here. But we have, if you could imagine, these arrows pointing to squares that say engagement, work, and termination, which is sort of the traditional helping process. But we realized in our study of existing evidence-based practices that there were additional factors that weren't included, and we realized that there were a lot of things related to access of care that would be greatly impacted by culture. And we also realized that on top of all of this, there are specific cultural factors based upon the environment in which people live and work. So for instance, the Dominican community that is large and influential in the Washington Heights community near Yeshiva University is probably quite different than a Dominican community that's, say, in rural Indiana. So not only are we talking about cultural factors from where people originate, but really where they live and work currently. I wanted to show you this slide, and again, it's very hard for you to see, but you can access, we'll make available these slides to all the participants. But we wanted to show you that as you move through this cultural modification project, the toolkit has numerous tables with lots of examples to help you work through your community's own unique situation. So for each phase of the helping process, and we actually have 2 access phases, which you can see in the toolkit. So for each phase of the helping process, we identify multiple components which are described, and then we give you some reasons why you might want to make a cultural modification to that. And then we give you some selected examples to help your working group get started considering each of these components for cultural modification. Some implementation issues. This is the last major chapter in the toolkit, and while it's currently at the end of the process of the toolkit, we found that some of these implementation issues can be evaluated and addressed early on in the process. So agencies or systems that are using that may want to consider some of these issues at the beginning of the process. And some of the things discussed in this chapter are evaluating organizations' readiness for change. Because whether you are selecting a new evidence-based practice or adapting one that's already in use, this is going to create some change in the organization. So your organization, system, or agency may want to evaluate your readiness for change up front. And at the same time, you're going to want to think about the organization's overall level of cultural competence, and we provide you with information about that as well. And then there's some information on final implementation, and we're going to be expanding upon this in the next version of the toolkit and discuss things such as training. So I told you earlier that the toolkit comes with other resources, and these include a checklist and workbook to help people that are actually using this process to complete the process. As we completed the actual manuscript for the toolkit, we realized, wow, this could be really burdensome and difficult to track because, like I said, not every agency or system is going to be using every piece of every chapter. So we provide you with a checklist and a workbook with lots and lots of templates to help you work through the process. We also have an annotated bibliography that, again, we'll be updating, but that's quite robust now. And we also include specific instruments for helping organizations make these change. We have an organizational cultural competence scale, which was developed at the Nathan Klein Institute and is a really robust scale because not only does it tell you about your organization's current level of cultural competence, but it will help you through the evaluation process move on to higher levels of cultural competence. So where your organization could go from wherever you are currently. And then we provide you with some scales for readiness for change. And I wanted to also point out that the Nathan Klein Institute has completed and is currently piloting a program level measure of organizational cultural competence that we can also make available to you. So now I wanted to transition a little bit into how this toolkit has been used in practice. This is actually easier said than done because the toolkit itself was developed with public funds from the state of New York and is available for free. We knew that organizations were downloading it and using it, but it was really hard for us to determine who was downloading it and how they were using it and to what extent they were using it. What we do know is it has been successfully used in federal grants to show how cultural competence will be addressed. I know specifically it's been used in the Southwest with Native American populations in Circle of Care grants, but it has been used elsewhere. So to study how the toolkit has been used in practice, we decided to embark in an implementation study with 2 agencies in New York that planned on using the toolkit, and they agreed to let us follow them throughout their process. So in order to kick this off, we provided a couple of things. We provided training. This was at the request of the agencies to provide them with an overview of the methodology. We provided all existing toolkit materials, and that's really, like I said earlier, that's freely available to anyone. and I can show you where you can access it. And we were willing to provide technical assistance throughout the project because, again, this was funded with New York State dollars. We were able at that time to provide technical assistance to agencies in New York using the toolkit. In exchange for what we provided, we were allowed to attend all meetings related to the cultural modification project at each of the sites, and we received all agency-based exchanges such as notes, emails, and handouts that were a product of the project. So to provide you with some context, I wanted to tell you a little bit about the agencies that were using that were used in the implementation study. The first agency is the largest social service agency in a large northeastern city, and they decided to use the toolkit in one of their sites, one of their clinics, that was serving a large number of Russian-speaking seniors that were presenting with symptoms of depression. And this was really an interesting site because a lot of the time when we think about cultural incompetence, we think about, there's a lot of early termination from care, but that was not what we were seeing. We were seeing at this agency seniors and clients that just were not terminating because I guess their needs were not being met, and so they just never terminated. So this particular clinic was not serving as many clients as they would have liked to because there was never any termination for existing clients. The second agency was another large provider of social services, but it was in a predominantly urban suburban region. And the problem that they were looking to address was poor participation among African Americans in an existing evidence-based parenting program in a small city. So this was, they were already using an evidence-based practice that they were very well versed in. The folks that were delivering services were trainers and knew the model well, but they saw early dropout and poor participation from a particular group. So that's what they wanted to address. So what we've learned through our implementation study is that agencies actually can complete this project with master's level staff. While folks were initially a little bit nervous about being able to do this, we learned that skills from master's level staff were able to actually complete this, and they did a really terrific job. We also found that the initial training at the agencies was very important for understanding this methodology and the scope of the project. And I want to just emphasize that while we participated in the initial training, the trainings itself were initiated and driven by the agency, who provided an overview of the project for their entire staff and why it was being undertaken and what they hoped to achieve. And we just provided the training and an overview of the toolkit. And it was about, I think the overall training was a day, and our portion was about half a day. We also learned that while agencies do work with community members currently, forming the working groups proved to be a challenge. One of the things was that we wanted to help the agencies identify a constellation of group members that was appropriate given the circumstances of the work that they wanted to do. And we also found that as they were engaging community members, the agency staff at both sites kept gravitating towards other mental or behavioral health professions because they were worried that community members that were not well versed in mental or behavioral health issues would not understand the project. And what we explained to them and what they grasped later, which was terrific, was while these community members may not know a lot about mental or behavioral health, they know a lot and are true experts in their lives and their communities, and so they had a lot to contribute to the project. And the third thing was that figuring out how to explain the project to these community members that may not be well versed in mental or behavioral health in layman's terms and asking for participation in a way that is not overly burdensome was that needed some help from the project team. So we will be addressing that in later versions of the toolkit. We also learned that identifying possible evidence-based practices did also require some guidance on our part, and it required some more skill than some of the agency staff had, but with some technical assistance, they were able to do this quite effectively. And we also learned that the process of working with communities can be streamlined based upon agency and community needs, and that 3 meetings with the working group that included all the community members, meaning the working group that included the staff and community members from the outside, 3 meetings seem to be sufficient. And I do have some corroboration from that, from the Circle of Care grant that's being done in New Mexico. So I wanted to give you a little bit of feedback that we got about the project at both these sites, because both sites found them to be extremely helpful. So the project lead at one of the sites told us that the Toolkit project was really helpful. We got feedback about what the community needs, and the Toolkit process gave us direction and resources and strategies. She also went on to tell us that while this was very helpful, this really provided a context for applying skills that they already had within the agency, but it really focused them. This quote actually came from an agency staff member, and he said this at the last working group meeting to the community members that were part of the working group. And he was really the doubting Thomas of our group. He said, I was skeptical at first. The community wasn't asking for this. He meant the cultural modification. I felt it was our idea, and I had my doubts. Now I understand beautiful to us, because this really gave us a sense that this staff member, who was a direct care clinician, was going to really have a greater and deeper understanding of the folks he's serving. And the director of social services at another site told us that the project was really helpful to us. They're planning to repeat the process in the Latino community. So this also provided us with some sense that after going through this process with us once, they really were able to go ahead and do this on their own. So I just wanted to, before I open up the questions, to provide you with some follow-up where we're planning on going from here. The first is that the toolkit and workbook should be updated to reflect useful examples from the implementation study, and we're going to be working on that this fall. And we're still doing some work with the Nathan Klein Institute with the other authors to, again, continue to work on cultural adaptation. And we want to continue to provide technical assistance and begin to create a learning community for those doing these cultural modifications, so folks that are actually doing this can learn from each other. And finally, we are really, really interested in studying the degree to which cultural modifications done using the toolkit methodology actually improve outcomes for clients. We're assuming that it's the case, but you know, we're in the early stages of testing this, and we would like to do this more empirically. So I just wanted to provide you with our contact information, and the link at the bottom is available, and you can access the toolkit and workbook on our website. And so I just wanted to thank you for inviting us to participate today, and open this up to any questions that you may have.
Wendy?
Yep.
Can you please mute your mic so we can keep the feedback back? And I do have one question for you. Okay. The one question that's come up is, have you seen, when people have utilized or communities have utilized the toolkit, has there been a difference in its implementation via a rural and or an urban setting, specifically in regard to your example with the Dominican folks, you know, how different it is for them both geographically and culturally from different regions they've come from. So that was the question that arose. I'll punt it back to you.
So that's a really interesting question, and that's a terrific question. The short answer is that when that slide that didn't come out as well, where it says specific cultural factors, whenever a cultural modification is done, it's not just thinking about what is Dominican culture or what is Russian senior immigrant culture or what is African American culture, but it is what is African American culture in the context in which people are currently living and working. So the feedback that we're getting is that if we replicate this implementation of the toolkit in different settings, the implementation is going to look different. I hope that answers you.
It did. Thank you very much for your presentation, Wendy. And at this time, we're going to move on to the last section of our webinar and punt it to Mr. Esteban Zubia from El Paso, one of my favorite cities in the world. Esteban, if you can turn your mic on and your camera on, I'll punt it to you.
I'd like to say that most of you, or some of you, might know us as Border Children's Mental Health Collaborative when we first started, but our name has changed to Mental Health Support Services because we have expanded our scope of services, not only for the children and youth, but also for adults now. First, I'd like to get started with letting you know why we think that the cultural and linguistic competency is very important, why we looked at it here in El Paso. One is that we think that local culture provides a sense of identity for all communities and residents here in El Paso. Most people that when they hear about El Paso, they hear about a Hispanic community, and the language spoken here is Spanish, or the majority Spanish. But during our time that we did our first beginnings, and we started the culture and linguistics competency, I would call it an experience here in El Paso. We also had to look at this would identify the common understanding of traditions and values, or the different common understandings and values and plans of what we were going to do in order to improve the mental health well-being of the community. One of the things that we had to look at, and very, very strongly, is look at our population to see what we had here in El Paso. Several years ago, we got an influx of military here in Fort Bliss, estimated at 20,000 that we're going to be getting in. And with the Iraq war and Afghanistan and everything else, we had to really start looking at what we were going to be receiving within the community and the military, as far as PTSD and other brain injuries and so on and so forth. So we had to look at that population very closely and to see and prepare ourselves to see how we're going to do this, because they have their own, it is a culture within their own military residence. We also had to look at our Native American partners here in El Paso and find what traditions, what cultures they have. Also, we could not leave and not or ignore our LGBT population here. I think that is very important that we had looked at that at the very onset of trying to establish a type of communication with this population, because they're so segregated and many times in many communities, and we had to link our resources to them and find out what the needs were at that point. And most importantly, I think that we had to get the feedback of the parents and youth, because they're the ones that are in the front lines receiving services through mental health. And one of the things that we had to look at is and get feedback from them and seeing what issues they were seeing within the systems of care at that point. And that within itself, we also thought that it was important to provide local linkage and cultural biases for mental health care, particularly our providers at that point, which some were not very knowledgeable of what actually cultural and linguistic competency was. And the last thing that we had to look at the very beginning was the cultural linguistic competency serves to promote the local identity, very important in regional languages. Like I said earlier, because we are a Hispanic, majority Hispanic town, people just think that the primary language is Spanish, but within our own culture of the Hispanic, Chicano, or Mexican, whatever they would identify themselves, the dialogue itself is different in the languages that we have here in El Paso. We had to look at that also very closely. One of our biggest barriers that we had developing the culture and linguistics competency within El Paso was getting the buy-in from our own governance committee and private providers. One of the biggest questions was time. When we presented this on the different ways that we're going to establish policies and different ways that we're going to find the community to get a buy-in, was our own providers and our own governance committees, is how long is it going to take? Time is money, you know, everybody is busy. So that was one of the biggest barriers that we had during the time that we were trying to process how to implement our competency language and competency training that we were trying to do. What was done at the very beginning, and I'll talk a little bit more after these slides of what differences it made. One of the things that we established was policy and adopted the culture and linguistics appropriate services, the class, using the 6 domains. Keep in mind that we use this as a guide and not particularly as a driven force to establish our policy, but only as a guide to find out what really can be used out there in the community. The six domains, of course, is what the very first one is governance and organizational infrastructure. How were we going to really do this if we couldn't get the buy-in at the very beginning from our own governance team? So that was a challenge that we had to really look at. Was the very first domain that we wanted to work with. Of course, the second and third domain, the services and support and the planning and the continuous quality of improvement, that was fairly easy to do once we got the buy-in to do this. The fourth domain that we looked at was the collaboration. The collaboration not only within our partners out in the community, but the collaboration within the families themselves, the youth, their input, it's their voice, what did they think about what was going on, and the changes that we're going to try to implement within the community, and where we're going to get the buy-in from them. The other one, I think the two other important ones was the communication that we had, or the lack of communication that we were having within the community and the service providers and the other agencies that we're having. Again, I want to stress that one of the biggest obstacles that we had was they were concerned about time, how long it was going to take, if there was any money involved within their organization that they had to put up in order to make these changes. And one of the things that we work with very diligently is the workforce solutions here, and how to develop something that employers might take into consideration to implement the different culture and competencies that we were asking them to participate with in that aspect of the class. The second one is we provided training assistance to mental health care providers. Like I said, we had to get the buy-in from them, particularly within the professionals, not the front line, which was very important for us to start at the very beginning with a receptionist, that our clients were coming in and there was a lack of communication within the frontline staff. So that training that we provided helped them to identify the different types of issues that they were having with the particularly patients that had a mental health illness, or that did not understand, or got appointments on the phone, and the first line supervisor or the first line clerk gave an appointment for 10 o'clock. They got there 10 minutes later. They canceled their appointment without asking questions on how they got there. Many times what we found is that a lot of our clients were taking the bus, taking 2 or 3 buses. So that frontline training was very, very important on the onset of our development of the culture and linguistics competencies within the community. Also, we provided bilingual, bicultural literature, assistance, and respecting families as a primary source of identifying the needs. Like I said before, that was very important to us to establish at the very beginning on what we were going to do, what feedback we were going to get from the families that had some of the issues that were going on with communication and not being respected with their traditions and so on and so forth. We also use the 5 elements of cultural, and we had to start with our own organization, with our own department. And we thought that was very important because we had to acknowledge cultural differences. And for us to go out in the community and start training, we had to train our own staff first for them to understand and acknowledge what cultural differences there are out there in the community and how we're going to address those. We had to ask him several questions within their self-assessment, how they understood their own culture. Many of us, like I said, we have a hierarchy of different cultures, meaning that we have a abuelita, grandmother, that is 80 years old and has their own different traditions and their own different cultures. We have a younger generation that is completely different in their ways and the way they see their culture. So those are things that we had to understand and how we felt about our own cultures. And of course, engage the self-assessment and what we thought about that in ourselves and how we're going to present ourselves. Do we really know ourselves and our cultures, and to engage those that are outside outside our culture, how we're going to do that. And of course, acquire the knowledge and skills, like I said, in order for us to go out there and start the training and actually start acknowledging what different type of cultures we have out here. View behaviors within all cultures, our own organization, because of the issues that we were getting at the very beginning and the buy-ins that we were getting, we had to target the leadership. The leadership are the ones that make the policies, and the infrastructure starts with them. And if we don't have a good buy-in and have them participate in this, then it would be very hard for us to continue. We value the diversity that we had within our organization. Adopted diversity policies. We had to write the policies of how we're going to change our own department and set the values and provide the structure in order for us to provide the services to the community. So what type of services were we looking at? Conducted in a organizational level assessment, which helped us out a lot because many of our leaders had different ways of, I guess, conducting business, daily business, and not really paying attention to the cultural and linguistic opportunities that we had to start our work within the community. The toughest, I think, is to institutionalize the cultural knowledge within the organization, and that was a little bit hard because the decision makers and the stakeholders were really the ones that we had to convince in order for us to not spend a lot of time and not spend a lot of money in doing this and trying to provide this to our community. How we incorporated the culture competency standards into practice. Well, one of the things that we did was, of course, the second bullet that I want to go over that is really evaluate the intake and assessment documents, as well as the policies, procedures to be inclusive to our department. When our care managers, our counselors, and so on and so forth do the intakes and do the assessments, we had to really look at what we were asking, what we were doing, what type of questions, and go and really provide more of the information of the culture aspect of each client, the traditions that they have, and that would serve in the long run in their treatment plans and how they were doing these treatment plans. And of course, we evaluate our policies and procedures. At the very beginning, we started with policies and procedures in culture and competency, how we're going to implement, whether there was a plan of action and what we're going to do. But you run into, at the very beginning, we did run into some obstacles that we need to sit back and reevaluate. And I think that's one of the things that you need to do within your community is reevaluate. Communities change, population change. So there's a constant work that needs to be done to find out what really is out there, who's coming into your community, and how are you going to serve them. And that's best done within the buy-in of your providers that are already using the tools that you have provided them, the literature that you have provided them. So you have to go back, reevaluate, not only those that are outside in the community, but reevaluate your own staff and your own department to continue the work, because sometimes we do forget, we're very busy, but that's very important to reevaluation. We employed qualified mental health workers who were fluent in languages. We found through some of our surveys that we did within the providers is that some providers were using their grandma or grandpa to translate for the use of the child going into a mental health intake or an evaluation, so they wouldn't have interpreters. So some of the doctors or psychiatrists were using their own patients to translate to the parent or the grandparent on what was done. And that was very dangerous. There's a lot of terminologies that are medical terminologies that are used that can be interpreted wrong. And there we found that it was very dangerous. So our recommendations were, of course, fluent in the language that they speak, as well as fluency in the medical terms of somebody that knows actually what they're talking about and translate accordingly to what the doctor or the psychiatrist or anybody was trying to say. We understood the cultural biases of staff and provide training and address these educational needs. Of course, again, major things that we were looking at is, of course, the language barriers that we were having within the Hispanic population and someone that doesn't speak Spanish, or so on and so forth. So we did have to address those issues with not only our staff, but the other providers themselves. One of the things, again, to continue with it, incorporated of the practice we had is we had to really understand the culture biases in program design. How are we going to promote and implement a program design that was understood within our own staff, our own organization, but within the community itself? Our partners, what really did they understand about our program design, or did they understand what we're trying to do within the community, and to bring awareness of culture and linguistic competency within the community itself? Identify the resources such as natural supports, and the natural supports could be not only for our families and youth, but natural supports that the organizations have, the agencies that they have. And what were they going to do in order for our clients, our patients, to better recover when they go seek help from their agencies? We designed and implemented culture-sensitive treatment plans. Again, we went back to our providers as well as our staff and find out what really would be sensitive treatment plans that we're going to develop. One of the things that we looked at is at that time is if here in the Hispanic or Mexican culture, we have what we call culendarios, people that have herb medicines, they have different rituals for treatment. And some of our clients or some of our community members that we were serving did not agree with the traditional medicines and so on and so forth. They preferred non-traditional treatments. So we try to train our staff and other providers and how to incorporate, not take away from their traditions, but how do we incorporate both the non-traditional medicines with the traditional medicines, non-traditionals with what they believe, and with the traditional medicines that we were providing without harm. How could we incorporate both of those within the treatment plans? So that was really important. One of the things that we have is the hierarchy is that, again, we have the elders that will not do anything or will not seek any assistance or help because they're set in their traditions. So that was a challenge for us to find an avenue where both would be met and to have a better recovery for our patients, our clients that we're serving. Again, evaluate procedures of program and culture sensitivity and effectiveness. again, I cannot reiterate through the whole process is that we have to reevaluate what we're doing on a constant basis. We tend to forget, we tend to put documents away, we tend to not follow up with what we have been doing, and we really strive to reevaluate because it was very hard to get it started. So it's better to continue reevaluating than to start all over again. Our biggest success, and I think this was quite an accomplishment, is that many of the communities participated in the training offered and implemented our recommendations within getting the buy-in from the community practices, our community agencies, anyone that's serving our clients or serving the patients with a mental health issue or serious emotional disturbance. That was quite an accomplishment that we had. Many of them did participate. Many of them did start using interpreters. Many of them did start using the literature provided to them in the different languages that we provided them. So that was a great accomplishment for us, a biggest success that we had. And then I think one of the other biggest success that we've had is the continuation of our staff and our organization to continue with this work. We have grown from, I guess, 4 years ago, from three staff members to 15 now. So that's quite an accomplishment. And to continue the practice of cultural linguistics and providing the services to the community, not only to the local outside community, but to our military that have come, has grown quite a bit. Like I said at the beginning, we have over 20,000 soldiers here in El Paso now that have issues that we need to start or continue to service and to find out what the needs are within that population. So my last slide here is the suggestions for the communities that are coming about. I think that it's very important to start within your own organization with the self and organization levels of assessments. I think that'll help you with the infrastructure of what you need to do in the long run within your communities and teach you what really is out there and what your staff members and your organization really know about the culture and language competency and how you're going to address it locally within your organization first before you get out. The next thing is that what I did at the very beginning, because it was very new to us here in El Paso and trying to implement the cultural and linguistic competency program here in El Paso, is that we used our grantor, our partnership, our TA partnership. I think I used it to the max. I think our partner, I don't know if he's online or not, Ken Martinez, who was very instrumental in helping me establish policies, procedures, and to really establish something out in the community. It was a great asset to us at the beginning. And also don't start disseminating cultural and linguistic literature and materials early within your community and agency. Start talking to them, even though if communities are not responding to you, dropping off the literature materials and then coming back and following up to see if they've read it or if there's interest. I can say for us when we start doing that, they're disseminating a lot of the literature and not only for the feedback was not coming back from the providers, but the feedback was coming from the families. We're actually waiting in a waiting room, reading these literatures and asking questions to the provider. What it was and why did they have this, or how could they get help on this issues and so on and so forth. So that helped a lot at the very beginning. So I really appreciate having you here or invited me to speak here and what we did locally in El Paso and what helped us. And hopefully some of the things that I have said you could use within your community and start the development of your cultural and linguistic competency program there and start actually helping the providers and everyone else that is involved within your community to address this very, very needed issue. Thank you.
Thank you, Esteban. I really appreciate your feedback on that. There was one question posed to you, and then we'll wrap it up. The question was in regard to the institutionalization of cultural linguistic competence, and specific to getting the organizational buy-in. And did you have any big wins with that? Was there an organization that seemed to buy into it and institutionalize it in a way that made it successful?
Yes, we did. It was our local authority here, mental health authority, that we started the works. Although they did have a lot of the materials and the techniques and they were doing a lot of what we already were discussing, except there were, like I said, follow up and the organizational aspect of it. They had to buy in within that and disseminating the information within all their agencies within the local authority, and I think that was the biggest. And what they did, they certainly institutionalized the program of being more competent, cultural competent and linguistic. Although they had some, I think that we went a long ways in providing them a lot more information. Like I said, a lot of them, a lot of the agencies that did have the buy-in had the buy-in at the very low end, I guess, levels of the organization. Except when you get to the decision makers up there and the stakeholders who are really making the decisions, those are the ones that really went in and got the buy-in and institutionalized the program itself, or the cultural and linguistic competency.
Again, on behalf of the Asset team, I'd like to thank each of the presenters for being a part of our effort today, and for each of you guys who managed to sit through the webinar today and didn't have too many terribly bad audio issues. Thank you for participating. Just so you know, I've placed a link to the closing survey in the chat log if you would like to click on that hyperlink and complete that survey. It's brief, won't take you more than a minute or two, and at the end you'll be able to download your CEU certificate. Also, when I close this meeting, the browser should kick you straight over to the survey. Just close it if you've already taken it once. The last thing I'd like to mention is, if you could, if you're interested, or if your community folks are interested, please view our other archived webinars, System of Care 101 and Not About Us Without Us, Family and Youth Voice, both of which are available on our website at txsystemofcare.org. You also get free CEUs for those for attending. So thank you, and I hope you join us for our next event.